Hello everyone, this is Qanitha Samar from Medina Cardiac Center. It's a great opportunity to present this article in front of all, and thank you for the invitation. Let us begin with the review article which is ongoing in our center with the mentorship of my cardiologist who is associated with the Saudi Heart Association. The topic is about in utero aortic valvuloplasty to prevent hypoplastic left heart syndrome. This is also known as fetal aortic valvuloplasty and intrauterine aortic balloon valvuloplasty. Can you move on the slide, please? So let us see what is hypoplastic left heart syndrome. It's a critical condition where the left heart is underdeveloped and reduces the systemic blood circulation. The causes are multifactorial and unknown. Sometimes the cause for this is genetic. And hypoplastic left heart syndrome can be secondary due to the other congenital heart defects like stenotic valves. And it occurs in up to 3% of the infants with congenital heart diseases. Critical aortic stenosis in mid-gestation period may lead to the myocardial damage, and eventually it results in hypoplastic left heart. And it's a critical congenital disease and need to be treated by the series of surgeries at the very young age. There are surgeries like Norwood procedures, Glenn, and ending up with the Fontan. So theoretically, early relief of this fetal aortic stenosis could preserve the function and flow of the left heart in the uterus, and it may prevent the hypoplasty of the left heart. Yeah, can you please move? So it's an emerging intervention rightly performed in early 1990s to reduce the burden of the surgeries in neonates. And it has the potential to prevent progression of aortic stenosis to hypoplastic left heart syndrome. So it starts interrogation from prenatal scan in the mid-trimester, which is beneficial for the diagnosis of the critical aortic stenosis, and then can be followed up by the fetal echocardiography to confirm the defect and its severity. The next slide, please. So with the help of the echocardiography team, cardiologists, OB-GYN, and anesthesia, the FAV can be performed using ultrasound guidance and a catheter-based approach to gain access to the fetal heart. Subsequently, opening the aortic valve using a coronary balloon. This increases the blood flow through the valve, LV, to help its development and potentially reverse the progression of the hypoplastic left heart. The next slide, please. So this is an image demonstrating the simultaneous echocardiography guidance and the catheterization needle inserted through the maternal abdominal wall into the fetal chest wall just beneath the aortic valve, and then dilating the valve, opening the narrowed valve. So next. So the criteria for the FAV should be tested with the severe, if the patient is severe AS with LV length Z score of more than -2, and if the retrograde flow in the transverse aortic arch is visible, then if you note left to right shunt across the foramina vallis, a monophasic mitral inflow pattern, and significant LV dysfunction, all these criteria suggest for the FAV. FAV for mid-gestation aortic stenosis increases the probability of postnatal biventricular circulation. It improves antegrade flow across the aortic valve. Technically successful FAV favors the transplant-free survival up to the age of 6 years. according to the research studies. To achieve technical success, the position of the fetus is important. Preferred position is dorsoposterior position. If the position is a complication, then fetoscopy assisted fetal posturing can be applied to obtain the desired position in the matured fetuses. It's an, can you just go back?
Yeah.
Okay. Fetoscopy is a procedure which replaces the maternal laparotomy. And fetoscopy should be used in matured fetuses because there is a risk of ruptured myocardium. And the expert team under one roof for the safe maternal fetal management can achieve technical success. Yes, you can. Technical success here is determined by the immediate forward flow across the aortic valve and mild to moderate degree of aortic regurgitation after the birth. And after 1 year, the LV length ratios to LV pressure estimations have favored the improved biventricular function. Okay, next. The risk factors of FAV is less, and there is no harm to the maternal side. The fetal damage remains still as a risk factor, though it has been practiced from long now, and morbidity remains. The success and management of the evolving FAV can be achieved only if the team is strong under the one roof. It means all the anesthesiologists, echocardiography team, the cardiologists, OB-GYN, pediatricians need to be under one roof to provide the safety, care, and postnatal management. And the success is of FEV can be determined by low mortality rates. And according to the AHE and AAC journal, FEV provides a modest medium-term survival benefit over expectant fetal management. So appropriate patient selection and low risk of fetal demise with FAV are critical factors for obtaining a survival benefit. Patient selection for the FAV, enhancing the pre-procedural counseling and focused research and clinical attention on the risk factors and associated lesions like MR, sometimes restricted atrial septum or intact atrial septum can be complications for FAV and can be technically unsuccessful. So all this keep planning before prior to surgeries is indeed important to improve the benefit of FAV in near future. Let's see. So results with the success birth rates after FAV are increasing. So it's a positive outcome with a 75 to 85% and death rates being 10 to 20% respectively. And moderate increase in biventricular circulation. It enhances the expansion of the procedures to be widely practiced around the globe to reduce the surgical intervention. Hope this short video is helpful so that we all together can reduce the burdens of surgeries and make the interventions like catheterization procedures more in implementation. Thank you.